Hi, so this short talk is just going to provide an outline of anemia and give you some classifications and structures to work with. There's a lot more detail that you need to know about specific anemias, and I'll try to highlight these, but really that is something that you would need to read. So by the end of this session, you should be able to define anemia, classify anemias according to cell morphology and etiology, and list the common causes of different types of anemias. You should have a little outline of the clinical features of common anemias, and you will, not from this lecture, but eventually with your studying, you will need to be able to discuss the investigation and emergency management of anemia. Sorry. So we're going to just go through two cases, and as we go through the cases, I want you to think about what you think the diagnosis is, what further tests you want to do, how this patient might present, what complications might arise. The first is a 14-year-old female patient who presents to the emergency department with a 2-month history of lethargy and exertional dyspnea. On examination, she is pale and mildly short of breath. So this is her blood count. What you can do is just pause the video, have a proper look at this blood count, and then come up with some diagnoses. Here's the second case, a 36-year-old male patient with pallor and shortness of breath. Again, pause the video, read this clinical vignette, then have a look at the blood count and see if you can come up with some diagnoses. So how do we classify anemias? Okay, again, just pause the video and see if you can come up with some classifications of your own that you think might be useful. So when we think about anemia, this really means a situation where we have a hemoglobin level that is below that required for normal physiological functioning, and according to whether it's a male or female, this may be below 10 or below 11 or 12. When we're thinking about classifications, there are two main classifications that you will come across. The first is a classification based on morphology, and this includes microcytic, normocytic, or macrocytic anemias. And this is useful clinically because when we get our blood count, we will see the red cell morphology, and therefore that's a common starting point when we're thinking about anemia. The second is based on etiology, and this helps us think about the pathophysiology and therefore the cause of the anemia, and working backwards from there, what treatment might be necessary. And therefore the etiology can be due to decreased production, increased destruction, and the increased destruction could be acquired hemolytic anemia, which can be immune or mechanical, or congenital. And congenital anemia, hemolytic anemias can be due to hemoglobinopathies, thalassemias, or other causes. Then again, there's increased loss of red blood cells, usually due to bleeding. So when we think about the classification of anemia according to red cell morphology, these are some of the common causes of microcytic, normocytic, and macrocytic anemias. Of course, the first things that jump to mind are the nutritional anemias such as iron deficiency and folate, but bear in mind there are other things that cause microcytic, normocytic, or macrocytic anemias. It's important to know these causes and have a little idea about the pathophysiology and clinical presentation of the more common ones. It is important that we know about nutritional anemias. I'm not going to go into great detail, but I'll just give a brief outline of each of the common ones. So, iron deficiency is a microcytic hypochromic anemia, often due to chronic slow blood loss, but can also be contributed to by poor diet, a diet low in iron. Folate deficiency is macrocytic and megaloblastic, often associated with a poor diet, and can be exacerbated in pregnancy when the developing fetus takes high levels of folates from the mother, and therefore the mother risks folate deficiency. An important correlation here is that folate deficiency in the mother is associated with neural tube defects in the baby. And finally, B12 deficiency, which is again macrocytic and megaloblastic. It's most often due to poor absorption in things like pernicious anemia, but can also be due to diet, and in our setting, vegan diets such as seen in Rastafarians can cause B12 deficiency. Of course, one of the key things in B12 deficiency is that it can be associated with neurological complications. It's really important that you understand the detailed pathophysiology of the anemia and the neurological complications seen in B12 deficiency. So let's go on to some more cases. Case 3 is a 56-year-old female patient presenting to the emergency department with pallor and tiredness for 2 weeks. She's icteric and pale with an enlarged spleen, and this is her blood count. Again, pause the video, see if you can work out what's going on here. Yeah, this is a patient with hemolytic anemia. So hemolytic anemias can be, as we discussed before, acquired, which can be immune or mechanical. Alternatively, they can be congenital, and this can be due to hemoglobinopathies, such as, well, the commonest one is sickle cell disease. Thalassemia, which is a quantitative mismatch in the production of hemoglobin chains. Cell wall defects such as spherocytosis or elliptocytosis, and enzyme defects, the commonest being glucose 6-phosphate dehydrogenase deficiency. We do need to have an idea of the causes of autoimmune hemolytic anemia, and I just challenge you to test yourself here. Pause the video and see if you can think of some common causes of autoimmune hemolytic anemia. So, drugs are common. Antibiotics such as penicillins, cephalosporins, and cotrimoxazole. Non-steroidal anti-inflammatory drugs and methyl dopa are some of the other drug causes. Infection, particularly these three: Mycoplasma, CMV, and Epstein-Barr virus. Autoimmune diseases in our setting, SLE, is quite common. And malignancies, chronic lymphocytic leukemia, multiple myeloma, and both Hodgkin's and non-Hodgkin's lymphomas. Let's move on to case 4. This is a 47-year-old female patient who presents to the emergency department with pallor and tiredness for 4 weeks, and this is her blood count. Pause the video, see if you can work this one out. So, this is a case of aplastic anemia, and if we go back, we can tell this because all the bloodline cell lines are depressed. But also, the reticulocyte count is very low. Usually, if you had a low hemoglobin, you should stimulate reticulocyte production. So, aplastic anemia is due to bone marrow aplasia, and this might affect just one cell line. So you can get pure anemia or pure thrombocytopenia, for example, or even pure neutropenia. However, often it affects all cell lines, giving up pancytopenia. The cause of the marrow suppression could be immune mediated due to marrow toxicity, cell death, or marrow replacement and infiltration. And the common causes are drugs, toxins, radiation, overwhelming infection, HIV, or certain malignancies, both hematological and solid tumors. So that was a brief outline of anemia. As I said before, many of these individual conditions you need to know in much greater detail. So you can use this as a basis to start your studies and then do some more reading around the specific anemias that we've encountered. And in summary, we've looked at two classifications of anemia: a morphological classification and an etiological classification. Hopefully, this will help organize your thoughts when you are faced with a patient with anemia. Thank you.